Should patients be obsessed with or overly concerned with the idea of a cure for myeloma?
I'm sorry I was late. There were churros out there. And I never get to eat churros. So that's a really tough question. When we think about curing cancer, we think about treatment over a fixed period of time with an expectation that the cancer will never come back. And right now, with our current available therapies, our current technology, we don't have that type of cure that we can rely on. Having said that, that doesn't mean that there aren't people who get therapies and never need therapy again. But that is very much the exception, not the rule. And so I think, I will simply answer your question, and I would say the answer is no. I think myeloma is the type of disease where there's treatment, there's intense periods of treatment, there's periods of low intensity therapy, and there's periods of no therapy, with the recognition that after low intensity therapy or no therapy, the myeloma usually comes back. And so thinking about optimal therapy that keeps the myeloma away longest and living the best for however long that is what I would currently be obsessed about as a myeloma patient. Now, as a clinical researcher, we should be obsessed. We should be the ones to be obsessed about, can we identify a cure for myeloma? I'll do this.
I'm going to agree that the answer would be no. I don't think we should be upset, or patients should be obsessed with the word cure. Ideally, yes, we all want a cure, but we don't have a cure for hypertension. We don't have a cure for cholesterol. We don't have a cure for diabetes. We don't have a cure for rheumatoid arthritis. Yet there's a lot of people in the world who have these diseases and have to be taking a pill or have to be taking a shot and continue to have a normal lifestyle. That's what I think we should be obsessing at this point. Myeloma has become a cancer that used to kill people within 3 years, and now it's becoming a chronic disease, just like diabetes and hypertension. The thing that we need to be focusing on is, until that cure does happen, what treatment can I have to maintain my disease controlled without giving me too many side effects, and so that I can continue to enjoy a good quality of life. That's what I think you guys should be obsessing about, rather than the cure or the drug that's going to put you guys into a cure.
Yeah, I think it's a pretty unimportant question. I think that just like high blood pressure, which kills 100 times more people than myeloma, no one asks about a cure. They just get under treatment and get it under control, so it's not a problem. And if you ask Magic Johnson, 27 years into it, if AIDS is curable, it's not. But he's doing okay. And so I think the issue here is you have myeloma until you die of something totally unrelated to multiple myeloma. And that effectively, I would declare success. But to think about what I need to do so that I have to take no medications for the rest of my life, and if you're cured, there's no need for surveillance. You just forget about it. You don't have to be checked. I think that is not a correct concept.
I have nothing further to add.
He's going to do this every time. I know him. This is not fair.
It's a rare moment when Hofmeister is speechless. Second question I want to ask is, I'd like for you to sort of go into your own personal time machine, and knowing what you know now and thinking when you started treating myeloma patients and thinking about how you'll be treating myeloma patients from 10 years from now. What's the difference in the conversations that you have with a newly diagnosed patient today as compared to when you began? And we have, you know, some bright young people like Dr. Rodriguez, Dr. Gertz. They were still trying to figure out fire back then, weren't they?
My first myeloma patient was shortly after the purchase of Manhattan.
Oh, okay, that's what I thought. So what's the difference between that young doctor who treated his first or second or third newly diagnosed patient with the doctor you are today, and what do you think that conversation is going to be like 10 years from now?
Okay, so in 2004, when I started doing more myeloma, thalidomide was still hard to get people to start using. VAD, vincristine, adriamycin, dexamethasone was one of the most common initial treatment regimens, and less than half of the patients had a partial response or better to treatment. And currently, greater than 95% of patients have a partial response or better to 3-drug therapy. And so you can tell them that almost any 3-drug cocktail is going to deliver a good response to almost every patient. And so the discussion is very different when you initially start treatment. And as far as the pace of change, every 6 months my table about how I treat patients and which patients get what, et cetera, changes. Where new drugs, and as far as the future, I think about the slide that I have that lists all the available treatments and all the available mechanisms of drugs that are in clinical trial. And somebody asked, well, where are we going to be in 5 years? And I just deleted the drugs on the currently used and just went with these drugs over here, which is where things are going. And that's literally what I think is going to happen. The drugs that are in trial today, the cell therapies that are in trial today, the next generation, the 3rd generation, 4th generation of those therapies are going to be how we treat myeloma. So I have moved since then, so I do not have direct contact with this moment.
10% of transplanted patients essentially are alive at 15 years. But I kill you on this. This is just, you know. So again, when I started after Plymouth Rock, so let's just go through this. No Velcade, no Revlimid, no thalidomide, for good or bad, no dexamethasone, no G-CSF growth factor, no Zometa, no Levaquin, if those of you have been on antibiotics for it. At the time, sulfa wasn't being used in prevention of rare pneumonias. A bone marrow transplant meant that we took you to the operating room, put you under general anesthesia, and collected a quart of your bone marrow. That's what was frozen. And that's what you got back after you got your ablative chemotherapy. We had 2 drugs, melphalan and prednisone. Those were the drugs that we had available to us. We had vincristine. Yay. And you got that, and you actually got it for 3 years. It was 36 months of therapy, which was dangerous because at very high risk of second cancers. But that's all there was. And then you'd stop it, and then just wait for it to come back, which it would, because talking about complete responses or very good partial response or MRD negativity, that was a joke. Nobody ever looked for that because it wasn't possible to do. And you put them back on melphalan and prednisone again. Actually, it was right at the introduction of doxorubicin. Oh yeah. And adriamycin. Some people might have had Doxil in the room, and survival was about 2.5 years, just about. And diagnosis was probably not great because there was no PET imaging. MRI was something that you used in the chemistry lab to analyze molecules. And so now I've seen it in my time triple in that amount of time with a very ever-rising proportion of 10, 15, and now 20-year survivors of myeloma. And the plate and the menu that I've heard Dr. Kaufman present, Dr. Rodriguez present, it's staggering in terms of the possibilities. And so it only can get better and better and better. You kind of, I hate to say it, you had to be there to really get knocked off your feet to see what's going on.
There on some levels there's clearly the outcomes are better, but our overall philosophy of therapy for newly diagnosed patients is still similar to what it was 15 years ago. We do an initial therapy, a transplant, and maintenance therapy. Our drugs are much better. I think the potential transformational event in myeloma is going to be how can we figure out how to use these immune therapies interspersed within this new diagnosis, either replacing transplant or adding to transplant, trying to drive to lower and lower levels of disease. And the other thing, so that's from a treatment perspective. From a monitoring perspective, I think we're going to get more sophisticated as we move forward, as these MRD technologies become more widespread, as they become easier to use, as we can start looking at low levels of disease in the blood as opposed to having to do marrows on a regular basis. It's possible we're going to start treating like our colleagues who treat chronic leukemia. It's not the analogy is not perfect, but if they don't wait for their disease to get symptomatic before making treatment changes, they're looking at molecular changes to make treatment changes, and I'd predict that we'll be there in the future also.
So I was not alive when Manhattan was purchased. Nor when Dr. Gertz graduated from medical school, probably. So when I started practicing myeloma, I did have bortezomib or Velcade to play with, and Revlimid, lenalidomide, and dexamethasone. But we still had a limited amount of treatment options that we could use. And we had in our mind that we had about 3 or 4 treatment options or combinations that we could use. So we were very stingy. And we were trying to hold off on when to start a treatment because we knew that we only had a set amount of treatment options. And our time was counted. So the moment we started the first treatment, we had to check one of the treatment options off. So we were really waiting until somebody had organ damage or had symptoms that required starting therapy. Nowadays, we have many options. And we don't need to be penny pinchers and waiting until somebody has symptoms or has organ damage. We can afford to try to start treatment a little bit earlier. So we try to pull the trigger a little bit early in time, knowing that later on, when they do relapse, we have other options. So that has changed since I started to now, which hasn't been that many years. But and then the other thing that has changed is when I first started doing this, we would start a treatment and try to get the best out of it so that we can then delay the next therapy as long as possible because we had the limited amount of therapies. And nowadays, we're starting a treatment and then we're trying to get the best response or try to keep people in remission the longest so that we can give time for a new treatment that's going to come out or a new clinical trial that's going to come out. And that's something that back then we didn't have that many studies. And nowadays, we have new drugs popping out on a yearly basis and we have to be keeping up with this. So when somebody comes to me with a new diagnosis of myeloma, I tell them, okay, the treatments that we have are more effective, and we can afford to start the treatment earlier on and to not wait until the other shoe drops. But then I need to keep your disease under control long enough for a new treatment to come out. And that's kind of what's changed, I think, in the way we think of when we treat myeloma.
Before we go to the Q&A, I'd like Dr. Rodriguez to take a minute, no more than 2, and I'm asking you an impossible task. Could you please explain what your MCRI project is?
So, like I said, there's a lot of new drugs that are coming out every year. And when somebody gets a new diagnosis of myeloma, we kind of have our go-to regimens, whether it be VRD or CyBorD or KRD. Those are the kind of go-to ones. But whenever somebody relapses, we have all these new goodies that we can play with. And we know that we normally want to combine the different medicines into 3 triplets, or sometimes 2 if they're 2 but normally we want to do triplets. So if you take the 17 drugs that are available right now for multiple myeloma, and you mix and match, it gives you at least 30 to 40 different combinations. And which one's the best one for you when you relapse? Nobody knows. We have no way of knowing which is the best therapy for you. We do have cytogenetics and things that are going to help us guide us and eliminate some of those, some of the treatment options and focus on a specific number of them, but we still don't know which one's the one that's going to hit the nail in the head. So what we're doing right now with the grant that I got is we're taking, whenever somebody has a bone marrow biopsy for treatment, we take some of that bone marrow aspirate, and then I'm taking it to the lab, and I take the bone marrow that has the myeloma cells, and then all the other cells that are inside the bone marrow, because it's important for myeloma cells to live around the cells that are in the bone marrow to stay alive. And it's also important for those myeloma cells to be around those cells to develop resistance to chemotherapy. A myeloma cell on its own doesn't survive. It depends highly on all the cells that are around it in the bone marrow. So we're taking the bone marrow aspirate, and then we're mixing it with a substance to turn it into this gel that is an ink. And then I'm putting this in a printer, a 3D printer. And we're printing miniature versions of the tumor from that patient. And we're obtaining up to 200 miniature tumor versions. And then in the laboratory, I can then mix and try different chemotherapies at the same time. And hopefully, within a week, get a readout of all of this and say, okay, out of the combinations that I exposed these tumors to, which is the one that killed the most cancer cells and which is the one that was the most resistant. And just like whenever somebody has a blood infection and they do a blood culture, and it gives you a result as to what type of bacteria you have and then what antibiotics are the most sensitive to and the most resistant to, that's what we're trying to do with this test, which is called an organoid model, so that we can then read out what are the chemotherapy combinations that are the most sensitive to and which ones are the ones that don't work. So that then your doctor can get this result and say, okay, I'll take number 1. And then if for some reason it's a contraindication because you have heart failure, or you have bad lungs or something, okay, then I'll take number 2 and go like that.
Not bad.